Hi, this is Phillip G. from the University of Texas MD Anderson Cancer Center, Section Editor for IGIE's Historical Considerations. It is important to understand the past in order to investigate into the future. In the 1960s and 70s, the prevailing wisdom within the medical establishment was that cancer was caused by environmental factors. That paradigm was so deeply entrenched that challenging it took a dedicated family of investigators working with countless families over careers that spanned multiple generations. Those hard-won discoveries that changed this paradigm fundamentally changed our understanding of colorectal cancer and of cancer in general. Although there are many eponyms in medicine, the story of hereditary nonpolyposis colorectal cancer, better known as HNPCC or Lynch syndrome, embodies the spirit of investigation. We are therefore delighted and honored to have the opportunity to interview Dr. Patrick Lynch as our distinguished guest for the Historical Considerations section of IGIE. The son of Henry Lynch, Dr. Lynch was intimately involved in the discoveries and investigations of the genetic disorder we now know as Lynch syndrome. Although the biography of Lynch syndrome from the perspective of the father has been previously published, the biography of Lynch syndrome from the perspective of the son has not been previously reported. A major figure in his own right, Patrick Lynch independently established himself as a renowned scientist and physician over the span of a 34-year illustrious career at the University of Texas MD Anderson Cancer Center. Humble yet outspoken, Dr. Lynch reminds us of the incredible hard work, dedication, and perseverance it takes to become a successful investigator in gastroenterology and GI genetics. Dr. Lynch, thank you so much for taking the time to provide this interview. What an honor and privilege to have the opportunity to interview you for this very unique story. Your father is obviously a famous name in medicine, and much has been written about his life and his career, but I do not believe this story has ever been told from the perspective of his own children. Tell me a little bit about your background, your family, your upbringing.
Well, I was born in Austin, Texas, but spent many years in Nebraska. My formative years, I guess, during grade school and high school, law school and medical school. So a lot of people think that I'm from Nebraska, but actually I'm originally a Texian and always planned to come back. My early years were in Austin, where my dad was in graduate school in genetics. And then we moved to Galveston, where he was in medical school at the UT medical branch in Galveston. And that's where my sisters were born. And then we wound up in Nebraska, where I was just a kid going to elementary school. And he was a internal medicine resident and medical oncology fellow at the University of Nebraska. In about 1967, he took his first real job, academic job, post-training, actually at MD Anderson, and was there for a year and a half. And then we moved back to Nebraska because he got an offer to be a department chairman at Creighton and to have the kind of autonomy that he really wanted to have. So to kind of weave, I guess, his story and my story together, his work was always characterized by descriptive research, really, collecting families with various types of cancer clustering, not just colorectal cancer, but he did a lot of work which probably has not been recognized as much. A lot of work in familial breast cancer, melanoma, what's now called Li-Fraumeni syndrome, and other similar conditions. And that really began in the 1960s and continued, during his whole career. So what's that got to do with me? So we did not always see eye to eye, and he always wanted me to be a doctor. And I basically was just being oppositional and decided I didn't want to be a doctor, emphatically did not want to be a doctor. And so I was a child of the late 60s, Earth Day, and I decided I wanted to be an environmentalist. and thought the best way I could do that would be to be an environmental lawyer of all things. So I raced through college and went to law school and became disillusioned. It's a long story, but I became disillusioned with law, with environmental law. And I think it was mainly just because I was really too young. I wasn't really prepared. I graduated from law school when I was 21, and I think I was just too young to really take on the rough and tumble of a legal career, which is actually a good thing, because what it meant was when I became disillusioned, I had occasion to take a step back and think, okay, now if I don't want to do that, what do I want to do? So at this point, I was getting married, and my wife was just getting ready to start medical school. And so I decided I would tread water for a year or two. So I went to work for my dad, just really as a research assistant more than anything else, stuffing envelopes. We would back then genetics research was a matter of family reunions and drawing blood for laboratory studies to be determined. But in the 1970s, the laboratory genomics research was so primitive that right now we look back on it and say, we probably shouldn't have even been thinking about it. But so I loved drawing these pedigrees of these families, and I'd get medical records back from a hospital and would actually be able to kind of fill in the blank on a pedigree, saying, this one had colon cancer, or this one had something else. And so I got more and more interested in the GI aspects of this familial cancer business, and actually started finding it interesting. And so between finding that research interesting and my wife really enjoying medical school, I thought, well, maybe I'll go back and do my pre-med work. And I did. And when I started medical school just a few months after my wife finished, so she was an intern and resident while I was a medical student, and having kids all along. So we had a full house of kids by the time I graduated from medical school, and went off to Arkansas to do my internal medicine. It was one of the few places that was able to take my wife in the middle of her residency. People say, how'd you wind up in Arkansas? There are a lot of places I probably could have gone, but it was the only place that had a spot for somebody in the middle of a pathology residency. So we were able to both do what we wanted to do. And then I finished up there and went to Baylor. I had heard all these wonderful things about David Graham at Baylor, and I heard it was a tough program, but I thought, okay, that's what I need. And I don't want to make it about David Graham, but he's one of those people, and I've noticed a few of those people over my career, but he was always the smartest person in the room. And so it's good to have somebody like that as a mentor, somebody that already knows everything, and it definitely keeps one humble. So then after finishing that GI program at Baylor, I did what I had been wanting to do for a long time, which was to return to MD Anderson, where I remember kind of visiting the place a few times as a kid when my dad was there. And going to work for Bernard Levine, who was my boss for a number of years, and just one of the most truly wonderful gentlemen. You would have loved Bernard. He's retired now in New York City, but just an ultimate gentleman. And I just cannot say enough wonderful things about Bernard as a mentor and kind of a father figure. You'd love him. So anyway, so that kind of got me into my career at MD Anderson. Here I was a GI person, loved endoscopy, always loved endoscopy, but my academic niche, I decided from day one, was to basically replicate a lot of the stuff that my dad had done, collect families, be involved in their endoscopic management, not just HNPCC, but I've found familial polyposis actually in a lot of ways much more challenging endoscopically. And I know I've shared some of these patients with you, and I know you found them to be a bit of a challenge as well. So a lot of these other familial genetic conditions are in a lot of ways more challenging endoscopically than HNPCC is. But that's certainly in the early years that I was at MD Anderson, this is when all of the things were really happening to put hereditary nonpolyposis colon cancer. Some people call it Lynch syndrome after my dad. But it was during those first 5, 6, 8 years at MD Anderson that things really began to happen with HNPCC, because up until the gene for the first of the several genes were identified, there was a lot of uncertainty about whether any given family actually had this condition. And there were skeptics who said there was no such condition as HNPCC at all. It's just chance aggregations, and sure, some of them probably were chance aggregations, but now that we have the gene and so forth, we can sort it all out. So that's kind of a long-winded story, and I know I've left a lot of things out, but you'll do the editing and it'll be fine.
No, and the viewers can certainly read through the manuscript and see all the little details as well. One of the things that from an editor, the viewers may not notice is Patrick Lynch, JD, MD. So you certainly have had a very different view of medicine, I think partially because of your law background as well. If I remember correctly, you even taught medical legal classes during your medical school days.
Right. Yeah, and that was fun. That was interesting. That was interesting work. But and I've known a few people that have tried to practice law and medicine, but it really doesn't work very well. You have to find some sort of niche in one or the other. I knew a guy at Creighton, actually. He and his brother were lawyers, and they used to do a lot of malpractice and personal injury and that sort of thing. So he went to medical school because he thought it would make their firm look better somehow if he had an MD after his name. And the guy didn't even do an internship. He just went straight back to his law firm. So I thought, that doesn't make a whole lot of sense. But it just, again, shows that a lot of different people with those kind of backgrounds parlay it in very different ways.
Right, absolutely. And I'm sure, especially I think in the genetics field, when we talk about ethics and whatnot, there is a slightly different vantage point with that sort of background.
That's a very hot area right now. A lot of the issues of ethics and the issues around genetic testing and children and consent and issues of enforced, not enforced, what's the right word I'm looking for? Sort of inflicted insight. For example, if you have, you see a patient, they are interested in genetic testing, or they have colon cancer, and you test them and you find that, they're a mutation carrier, but their brother or sister doesn't want to have anything to do with it. But some niece or nephew is concerned and gets tested, and they're positive. Well, that sibling now is a carrier, whether they wanted to get tested or not. And so, you have these issues of a sort of inflicted insight in people that really didn't want to know. So it gets very involved. And these are not just hypotheticals. These are real life kind of situations. Right,
for sure. So, ironically and inadvertently, I guess maybe inflicted is the term. You did exactly what your dad had wanted you to do, and you went into medicine. And then there's a syndrome that's eponymous with your family name. With regards to your relationships and whatnot, did you ever feel pressured to follow in these footsteps, or did you really kind of feel the autonomy to investigate on your own?
Well, that's hard to say. So I will freely admit that um, having worked under him and sort of learned the ropes, I guess, from the master, uh, it made sense for me to do that, and it certainly, I suppose, opened doors. It made it easier for me to uh, be invited to give talks and to go to conferences and so forth. And so, it's always an interesting challenge to try to make a name for yourself when you know that you're actually very much following in the footsteps of somebody who did the same sort of work. But at least I didn't go into medical oncology. At least I went into GI, so as to focus on a different aspect of things. And I've always been very interested in prevention. And as an endoscopist, I always thought that identifying and removing polyps, for example, was more rewarding than dealing with cancer. And so it never really occurred to me to do surgery. And a lot of the chemoprevention trials that I've been involved in over my career, mainly in FAP, but a little bit in HNPCC, have really been all about pushing the idea of what can we do to reduce the risk of cancer.
Yeah, very good. So let's go backwards in time a little bit. We'll certainly come back and talk about some of your original investigations as well. I very much want to hear about how you got involved in investigations, how you got involved in all your chemo prevention trials. But let's kind of turn the clock a little bit here. When your dad was undergoing his medical training, the landscape of hereditary cancers was very, very different than it is now, and the understanding was very different. How did your dad get involved in this? Like, what was the original impetus to a young man who was going through medical school or working in a research lab? How did he get involved in this idea, and how did he turn that into a passion and a niche?
Right, right. Well, so just like my story was a long and winding road, environmental lawyer. Nah, I don't think so. I'll do something. So it seems like everybody's life is a long and winding road, and his was too. I'm not sure exactly what got him interested in genetics, but he, at one point, I think, wanted to be a psychiatrist of all things. And that's where he met my mom, was working in a psychiatric hospital in Denver. And for somehow or other, I guess I'll never know, he somehow got interested in the genetics of schizophrenia. And I have no idea what his genetic basis, if any, for schizophrenia is, but he got interested in the question of, does schizophrenia have a genetic basis? So he started off interested in schizophrenia and mental illness, and then migrated into an interest in genetics. And so that's what he did at UT Austin, was work on a PhD in genetics. But before his PhD was finished, he started medical school. So he had this background in genetics, which was otherwise kind of undifferentiated. So when he was a resident, one of his mentors, an oncologist, kind of said, "Oh, gee, Henry, you've got a background in genetics. Well, I've got some families that seem like they have inherited lymphoma susceptibility. Why don't you study those with me?" And again, it was all descriptive. And so he was sort of interested in these families with lymphoma. And to this day, I have no idea if any of them ever did show any genetic basis. But he actually had one patient that really made an impression on him, and it's been written about before, who had colon cancer very young, and was telling him the story of how everybody in his family had colon and related types of cancer very young. And so, what did we say? Opportunity favors the prepared mind. And so his mind was prepared in the sense that he was very open-minded about conditions possibly being genetic that were not otherwise thought of as genetic, like schizophrenia. So schizophrenia and cancer really aren't very similar, except in the sense that, nobody really thought there was any genetic basis. So, well, maybe there is a genetic basis. And so he read about it, and then he heard about this family from Michigan, and the so-called family G of Warthen, and he actually took over all of the records pertaining to that family and just continued working on that same family, and worked with this medical social worker, Ann Crush, who, after working with him for many years, went back to Maryland, where she was from, and actually worked with Francis Giardello, a good friend of mine at Johns Hopkins, at their polyposis registry. So they worked together on these families with various different types of cancer. And she actually spoke German, and they actually went to Germany once or twice to try to do some genealogy on this family that was of German extraction. So that was interesting.
Very interesting. And a lot of these families, these descriptions came from Midwestern families. Was there any particular reason why a lot of these studies were done in the Midwest?
Well, there were large families, large farming families. And when you're studying a disease that looks like it is or might be autosomal dominant with moderate penetrance, if you're studying a relatively late onset disease where people manifest with the condition in question, in this case cancer, in their 30s, 40s, 50s, 60s, it's always possible that in a small family, someone will die of another cause and not have any evidence of cancer. So the larger the family, the more opportunity there is to see evidence of autosomal dominant inheritance and the full spectrum of tumors, whatever that tumor spectrum might be.
Right. It's very interesting. And then eventually, I think, as a lot of the early papers have shown, coming from your dad, the study of all these families became a family affair. And I think that was after Ann Crush left the practice and went back to Baltimore. I think your mom joined the group as well.
Right. Yeah, she didn't want to. He forced her to. She was perfectly happy being a psychiatric nurse, but when Ann Crush left, he basically said, I need essentially an office manager to kind of manage my research and the research personnel. And so, she didn't really have a whole lot of choice, so she did that.
Right. And I think your father had the sheer force of will, if you will. I think he was like you said, 6'5", 350 pounds.
Yeah.
The sheer physical power there to get all of you guys in line.
Right.
Now, the condition was not originally called Lynch syndrome, obviously, and it was originally not even known as HNPCC. I believe it was known as a cancer family syndrome. So take us through the history of that. Like what happened with your dad, and then how did that lead towards these names and the eventual establishment of what's now considered Lynch syndrome?
Right. So the nomenclature is kind of shows a lot of historical evolution. People writing case reports, even in the 40s, 50s, and 60s, would refer to the so-called cancer family syndrome of Warthen, because Aldred Warthen, this well-known pathologist from the University of Michigan, people have heard of Warthen tumors and so forth, had described it. And I don't remember if Warthen himself ever actually used the term family cancer syndrome or cancer family syndrome, but that's what people tended to call it. So they call it the cancer family syndrome of Warthen. And so then when my father was churning out paper after paper after paper, people came to associate that condition as much with him or more. And so they would call it the cancer family syndrome of Lynch, or Lynch and Warthen, or Warthen and Lynch. But interestingly, the only really known cancer genetic syndrome in the 60s and 70s and 80s was familial polyposis. And so many people got HNPCC and FAP terribly confused because they thought, well, so why don't they have a whole lot of, they're supposed to have a whole lot of polyps, aren't they? Well, no, this looks like it's a different condition. So at one of the early working group conferences in about 1990, the issue of nomenclature came up, and a bunch of academics from around the world were arguing about, we need a better term than cancer family syndrome, because again, the Li-Fraumeni syndrome was sometimes called cancer family syndrome, so that got confusing. So people said, well, why don't we call it hereditary non-polyposis colon cancer to emphasize that it's not polyposis, to try to eliminate the confusion, and colon cancer, because colorectal cancer, because that was the main cancer. So the main knock that people have had on that term over the years is that it's a mouthful. Hereditary non-polyposis colon cancer is a lot to say. HNPCC is short and easy to say, but if you're not the cognoscenti, you'll say, what is that? HNP? I don't know what that is. And so then you have to say the whole mouthful. And so it was just cumbersome. Plus, it became evident that there were a lot of other tumors, endometrial and other GYN tumors, other GI tumors, and even skin tumors and so forth. So to call it hereditary polyposis or non-polyposis or whatever, colorectal cancer was considered a misnomer because it implied that colorectal cancer was really the only cancer of concern. And so Rick Boland, who is another one of those smartest people in the room kind of people, and I hope Rick has a chance to see this podcast. He's a dear friend of mine. He was an early sort of protege of my dad's. And Rick really has done a lot of important laboratory work. And for some reason, I guess just as sort of an honor to kind of a tribute to my dad, he wrote an editorial in some journal in about the mid-90s saying that we should call this condition Lynch syndrome. And it stuck. Other than, various, Oedipal considerations, the problem I have with Lynch syndrome is that people say, oh, gosh, Lynch syndrome, that must be you. And it's, well, no, it's not me. So that's kind of followed me around my whole life. And so it's always a little bit of a bittersweet sort of thing whenever somebody uses that term.
And that's why you're always so insistent amongst all your colleagues that it's HNPCC.
Yeah, right.
Well, very good.
So they're really interchangeable. They're exactly the same condition.
Now, at one point, I remember when I was going through medical training, that was even further subclassified. I remember, learning in some of my lectures, it was like Lynch syndrome 1, Lynch syndrome 2. Is that a bit of a historical relic at this point?
There are a lot of historical relics. There were the so-called Amsterdam criteria, clinical criteria for HNPCC, which had a reason for coming into existence, were helpful for a while, but then it became evident that they were insensitive, that many families have this condition even though they didn't meet those criteria. Similarly, the so-called Bethesda guidelines for deciding what sort of patients should have their tumor tested for evidence of microsatellite instability was helpful for a while. And there was a Bethesda and revised Bethesda. So again, nomenclature getting more complicated. Again, it became evident that those criteria were not adequately sensitive or specific. So it's often, once we really learn more of the nuances of any condition, the descriptors, the criteria, the features that we used to think were important are now just of historic interest. And so this so-called, Lynch 1 or Lynch 2 describe families that seem to have like only colorectal cancer versus those that had a much broader spectrum. And although it's kind of true, and I don't want to get out in the weeds, but families that have mutations in the EpCAM gene, which inactivates MSH2, seem to have a little bit more of a site-specific colorectal cancer, but the jury's still out on whether that's really even true. But we now know that there are no useful genotype-phenotype associations that would support really a so-called Lynch 1, Lynch 2, or colorectal only versus others. So no matter what a given family has had, a person has to always be open to the possibility that, especially in smaller families, that they just have not had a chance to manifest the full spectrum of tumors yet.
And so nowadays, the classification obviously is more genetic based, right? It's like saying somebody has an MLH1 mutation versus et cetera.
Well, and again, not to really get into the nuances of the different genes, but other than to say that I think a gastroenterologist who deals with cancer at all, or who does any sort of colon cancer surveillance, which I guess makes just about all of us, unless we're in some therapeutic niche or liver niche or something like that. Most general GIs spend a lot of their time doing cancer surveillance. And because HNPCC is relatively common, listeners, you do have patients, or you will have patients with MSH2 mutations, MLH1 mutations, MSH6 mutations, PMS2 mutations, and the phenotype, the disease severity, age of onset, spectrum of tumors does differ from gene to gene. So it's not enough. It's not enough to simply say that somebody has a family history that looks like HNPCC or Lynch syndrome, and it's not even enough to say that they have a mutation. But it's important to know, okay, which gene are we talking about? And it's really only been in the last several years that the clinical practice guidelines have gotten nuanced enough that they really insist that we specify which gene is altered so that we really know how high the risks are and what the spectrum of risks are for a given patient and family.
Sure, and it's very interesting. It's actually great that nowadays, we have all of the investigative work that's been done to elucidate a lot of these things as well. And we'll certainly come back to this actually, because I do want to ask you a little bit later in terms of what do GIs need to know about genetics? Because, I do get the sense, having interviewed you and having worked on this project with you, that there's just so much that GIs should know about genetics that we may not necessarily be aware of unless, we were to spend time with someone like yourself to learn these things. But to kind of bring things back just a tiny bit here. Some of the when you were starting off in this field, you joined a couple of very interesting groups, and then you co-founded a group as well. And being an official ASGE journal, from a society standpoint, we always emphasize the importance of joining a professional society, not only for professional connections but also for opportunities as well. Tell us a little bit about your role in various societies like the Leeds group and the nonpolyposis group. Tell us a little bit about the history of these things and where things went with that.
Right. Well, so again, the Leeds Castle group was really formed in Britain and mainly European and British Commonwealth with a focus on familial polyposis. And it was really the only international working group that was focused on any kind of familial genetic GI cancer-related condition. But it was a very narrow focus on FAP. And so although I joined that group, and they had meetings every 2 years around the world, and some of my dearest friends have been key members of the Leeds Castle group. It became evident that they really were not interested in things like HNPCC, that would somehow divert them from their main focus. And so people that were otherwise part of this Leeds Castle polyposis group thought, we'll have to form a splinter group. We'll not that we're abandoning this polyposis working group, but we need to start our own working group that's focused more broadly on this condition that we think exists, this HNPCC. And so I owe it to Paul Rozan, who died some years ago, an Israeli GI who hosted the first meeting in Jerusalem in 1989 or 90. And it was a very exciting time, the first few meetings, the meeting in Amsterdam where the Amsterdam criteria were formed and so forth. Everybody was really interested at that point in understanding what the clinical spectrum of disease was in HNPCC, identifying families to do linkage studies on to identify the genetic basis. And it just happened that at the very time that research in HNPCC was really taking on an international and working group perspective, that the APC gene for familial polyposis was identified. And so that proved once and for all that this condition that everybody knew was genetic, FAP, really had a clear definable genetic basis to the point that you could actually, in a youngster, you could do a genetic test to confirm that they were carriers of this susceptibility. You did not have to scope them. And so, before the gene was identified, you'd have to bring these young kids in, yelling and screaming, doing flex sigs, often unsedated. Imagine doing an unsedated flex sig on a 10-year-old. It's terrible. And so with genetic testing, you really didn't have to do that anymore. You only scoped them if you knew they were positive. So discovery of the APC gene really was a shot in the arm, if you will, to the international community. And it just, by coincidence, happened to be that at that time, the Human Genome Project was really getting very robust, that the molecular techniques for mapping genes was becoming very, very robust as more and more genes were identified. And again, not to make it a primer on the Genome Project, but many of the genes that were used in mapping studies to identify a disease locus like HNPCC or BRCA and breast cancer, many of the genes were completely unknown function. It didn't really matter what they did. It only mattered that they were that they could be located on a particular chromosome, that they were polymorphic, so that you could actually track their maternal or paternal lineage and so forth. And so it just became a much more powerful way of looking for candidate genes. And so it became very, very evident that, so the first thing the people did when they found the APC gene was they started testing what looked like HNPCC families to see if maybe it was some funny variant of FAP. And it turned out they did not, that all the families with HNPCC that got tested to see if they had APC genes, not surprisingly, did not have APC genes. So, okay, so this is not some strange variant of FAP. And so using the powerful tools of the Human Genome Project, several different labs around the world did basically a whole genome, kind of a shotgun, chromosome by chromosome evaluation. And then in 1993, workers in Albert Della Chapelle's lab in Helsinki, Finland, identified linkage to several loci on what became the MSH2 gene. And at that same time, because so they were not just doing genetic searches in isolation, they actually had to classify patients as being affected or not affected, because obviously misclassification can mess up your genetic linkage analysis. If you think somebody's a carrier and they've had cancer, and then it turns out that they didn't really have cancer, it can mess up the statistics that you're using. So they really needed to know who had cancer and who didn't. And so the people in De La Chapelle's lab were interested in issues about the tumor biology, the tumor genetics, and found that these tumors in these patients that were the subject of these linkage analyses showed some funny acquired genetic alterations. We know that all cancers acquire genetic alterations somatically, and some of them, confer resistance to chemotherapy and so forth. But it turned out that the tumors in these patients with HNPCC showed what they called, at that time, the term was replication error. So people in other laboratories had shown that people actually had microsatellite regions, repeat sequences that would become mutated and change in length. And so they became highly polymorphic in their own right. If they slipped, they might be a longer chain of CG repeats, or if they slipped a different way, it might be a shorter chain of CG repeats. And so a tumor would tend to show alterations in genes that had these so-called microsatellite regions in them. And so in the very same back-to-back article, they described linkage to loci accounting for what became the MSH2 gene, and at the same time said, oh, and by the way, these tumors themselves are very peculiar because they show this phenomenon of replication errors or of microsatellite instability. So then things really took off in both areas. The additional new genes, again, just like people look to see if HNPCC was an alteration of the APC gene. No, it's not. Well, then is all HNPCC due to this same gene, this MSH2 gene? And so other families were tested. No, there's no mutation in this particular family in the MSH2 gene, but they sure look like HNPCC. So let's go back to the drawing board and do like a whole genome search again. And then the MLH1 gene was identified, and then the MSH6 gene was identified, and then the PMS2 gene was identified. So in the mid-90s, it was a very heady search for new genes.
But I would imagine this was really exciting, especially for you at the time. I believe you were lucky enough to have been, it was your turn to host the international meeting here in Houston, right, Texas. Yeah. When all this came out.
Yeah, so so it was kind of neat. There was actually some press coverage. The people from Finland were here in Houston, and they had their 15 minutes of fame, and were being interviewed, and it was really kind of neat. It was really kind of neat.
Yeah, that's fantastic. And so since then, tell us a little bit about how our understanding of the science of HNPCC, like how has it evolved over these last 20, 30 years since the discovery of these mismatch mutation repair genes?
Well, so I think the story in the last 20 years has really been one of adopting and adapting the ever powerful molecular genetics tools that many GIs thought, and unfortunately some may still think, that this is all really basic science research and really has no relevance to my day-to-day practice. Because of the power of the molecular genetic techniques that have evolved, things got very, very mainstream very, very quickly. And this was accelerated. Again, switch gears for a second. The BRCA gene was identified at about the same time as the first HNPCC gene, and the BRCA gene was patented, and a company, Myriad Science, held the patent to the sequence of the BRCA gene. And so they were aggressively marketing genetic testing for breast cancer susceptibility. And so that sort of set the pattern for other laboratories, additional laboratories, aggressively marketing their ever more powerful and cheaper genetic testing paradigms, not only for breast cancer, but for colorectal and other cancers as well. And so one of the things that a lot of GIs may not realize is that the molecular genetic armamentarium that's used for genetic testing has actually been co-opted and captured by commercial private vendors. And in fact, many, many years ago, when these genes were first being identified, I actually went to Stan Hamilton, who was our chief of pathology and was very involved in the Johns Hopkins group and the APC gene and all that. And I said, Stan, shouldn't we get involved in the genetic testing field? Shouldn't we, offer an MD Anderson genetic test for susceptibility? And he basically said, and I think probably accurately, rightly in retrospect, that no, there are so many labs out there already doing it that we should just resign ourselves to the fact that they're doing it better and cheaper, and that we should just do send-outs. And that's what we do. We send out samples to one or the other of the various commercial laboratories that do this sort of work. And it's, I think anybody who's been in this field would have to admit to some degree of ambivalence about all of that. These laboratories are highly competent, very, very capable. They're all required to meet CLIA standards for laboratory care, chain of custody, quality assurance in the laboratory testing, and so forth. But at the same time, they're very aggressively marketing this, and particularly to the GYNs. A lot of our GYN colleagues in private practice, I don't know, probably once a year can expect a detail person from one of these laboratories to give them a sales pitch on why you should be using our lab to do, oftentimes it's BRCA testing, but while you're doing the BRCA testing, we'll test for everything else while we're at it. And so these panels of tests have gotten broader and broader, such that, in fact, there's been an interesting line of clinical genetic research that Matt Yergelin, Rick Boland's nephew, has been very involved in, of looking and saying, okay, you have a bunch of women that come in for BRCA testing, but that testing actually tests not only for BRCA, but for all the colon cancer genes and so forth, just because it's quick and easy and cheap to do. I wonder how many women that came in for BRCA testing actually wound up having an HNPCC mutation, or vice versa. People who around the country, for one reason or another, had genetic testing to see if they had HNPCC, but while we're at it, we'll test for everything else as well, breast cancer and so forth. And so the question of, if you have genetic testing for colon cancer susceptibility, what are the chances that you'll actually turn up with a BRCA mutation? And so that's a whole interesting field unto itself, and has really made it very, very clear that there's a lot of overlap in terms of the clinical features. And I'll just share one very quick anecdote. A member of my extended family, an in-law, was found to be a PMS2 carrier because her sister was tested for BRCA by her GYN because her dad had some sisters with breast cancer. And so, they did this panel, this big, huge, broad panel of tests. And not only did they not find a breast cancer susceptibility, they found a colon cancer susceptibility. And furthermore, it wasn't even on that side of the family. It was actually coming from the other side of the family that didn't have breast cancer. So, there's an awful lot. And again, this comes back almost to some of the medical, legal, and ethical sort of things. With a threshold for genetic testing getting so low, in part because of the aggressive marketing by the labs and the power of the techniques and the economics of it, it's getting very, very cheap to do this shotgun testing. You can test just about anybody for any reason, and what the genetic counselors that we work with have to absorb is, okay, you had no idea why you were having genetic testing really, but you had it, and now we have this surprising result. And so we need to kind of, peel the onion and kind of go through what it means to have that particular susceptibility that, neither you nor your family nor your doctor really thought was likely.
Yeah, and actually, interesting you bring that up. It kind of makes you wonder, what is the future of all this? Like, where are we headed, right? Are we headed towards an environment where providers, patients, and insurers may end up, adopting more of a universal testing approach?
Well, I don't know whether it'll come to this, but my prediction is that within the next 10 years, it's very likely that everybody will be tested for everything. We know that newborns have testing for inborn errors of metabolism, Tay-Sachs and things of that sort. And now anybody who's Ashkenazi Jewish is often recommended to have genetic testing to see if they carry one of the BRCA founder mutations that are very common in the Ashkenazi Jewish population. So if we've gotten in 2023 to where everybody's comfortable with considering genetic testing for cancer susceptibility simply because you're Ashkenazi Jewish, and we know that that's overrepresented in BRCA, the question becomes, well, why not test everybody for everything, not just cancer, but while we're at it, maybe you got a funny familial hypercholesterolemia that you didn't know was there. And also, and I'll just mention that there are some very, very rare recessive conditions that have a very severe phenotype that actually involve, for example, carrying two mutations in PMS2. You inherit one from your dad and one from your mom. And because it's actually the lowest penetrance of any of the HNPCC genes, neither your dad nor your mom may have colon cancer because, again, it's later onset. But if you have the bad luck of inheriting your dad's susceptibility allele and your mom's susceptibility allele, you may develop this condition called CMMRD, or constitutional mismatch repair deficiency, where you may actually develop a polyposis-like picture and colon cancer by the time you're 8 or 10 years old.
Wow.
Well, with a negative, as far as you can tell, a negative family history, no 7-year-old is going to get tested for some funny cancer susceptibility if there's been nobody in the family with cancer. But if we get to a point where even healthy people with no particular family history are tested, then we'll be able to pick up these very, very rare but very, very significant recessive conditions. And obviously, if there's any consanguinity in the family, first cousins or incest that's been unreported or unknown, we know that consanguinity tends to concentrate otherwise rare recessive alleles. And so, whenever you have any example of consanguinity, it should be maybe a heads up to consider genetic testing for rare recessive alleles that you may have 2 copies of.
Absolutely.
Or adopted people who don't know their family history.
Right. Even more.
More and more categories of people are urged to consider genetic testing as part of their broader health profile. So if everybody that's Ashkenazi Jewish or everybody that's got consanguinity in their family, or things of that sort, eventually, as the cost gets so low, I think we'll see that genetic testing gets offered to everybody. And then the only question is, do you do it as a newborn? Do you do it when you start college? When do you do the testing?
Right.
What do you do with the information? When do you disclose the information? If we test everybody as newborns and it turns out they've got an HNPCC mutation, that's probably not going to be important until they're 20. So, do the parents just sit on that information until the kid's 20? Well, maybe so. But these are, again, some of the ethical, moral issues that I think we'll be dealing with in the future. And certainly one option is, well, let's just not go down that path. But as I said, with the aggressive marketing by a lot of these laboratories, and the fact that we're already well into the slippery slope of lower and lower threshold for testing, I think the issue is not so much whether to test or not, but are we comfortable sending people to genetic counselors that can help unwind what the meaning of this testing is. So my take-home message to GIs is have a very low threshold for considering genetic testing. It's very easy to find a genetic counselor. Let the genetic counselor do the heavy lifting of a more detailed inquiry into the family and making arrangement for the genetic testing. Really all we have to do is have the thought that, maybe there could be some genetic basis for this. I don't know what the nuances of it are. I don't know what the details are, but I can sure find a genetic counselor.
Yeah, absolutely. And actually, that was one of the questions that I was going to ask you, which is, being as part of a GI endoscopy journal, actually we're compelled to think to ourselves, what should the GI endoscopist know about all this, right? By the way, I believe the GI endoscopy world credits you with the determination of right-sided colorectal cancers, the HNPCC, and your role in establishing colonoscopy as a screening modality over Flex 6. So, we all owe you our thanks to the colonoscopy world. But certainly, tell us a little bit about as a humble young endoscopist, what do we need to know, and what do we do with this information?
Right. Well, so one of the biggest problems to endoscopists, and there's actually good data on this, and it's distressing, very distressing data. The current recommendations for patients with a known mismatch repair mutation, MSH2, MLH1, MSH6, PMS2, at least in the U.S., is that people undergo colonoscopy beginning at age 20 to 25 for MSH2 and MLH1, and maybe 30 to 35 for MSH6 and PMS2. So again, we've nuanced the relative penetrance of the genes, and then repeat them at intervals of 1 to 2 years. Well, we like to tell our patients, gee, you have a normal colonoscopy, come back in 10 years. Well, that's for average risk people. And most people are, pretty comfortable with coming back every 10 years or 5 years. But when you tell somebody you have to come back in a year or two, that gets kind of challenging. Interestingly, the compliance has actually been pretty good. Most patients, once they've seen what's been going on in their family, they get pretty good about coming in every year or two. So that's good. But the distressing part is that there is a miss rate. As many as somewhere between about 7 and 14% of all mutation carriers will develop a colon cancer despite surveillance. So even if you, and I've had this happen to me. I've had it happen to me. You have a normal colonoscopy, or you remove a polyp or two, and the patient comes back in a year and there's a cancer. So we know one of the features of HNPCC is we know that there's an accelerated growth, that the polyps grow into cancer very, very quickly. And so if I find a cancer a year on, so did this cancer really grow from nothing in a year, or did I just miss it last year? Was it a little polyp? Was it behind a fold? Was the prep not great? And I think the short answer is it's a combination of the two, that the lesion probably was there, and I just missed it, but it was very small and subtle and just grew like wildfire in the span of a year. And so we know now that even with intense surveillance, as many as 7 to 14% of patients will develop a colon cancer despite surveillance. So we cannot guarantee that we'll identify and remove every polyp and keep them free of colon cancer their entire life. The good news is that the outcomes tend to be very good for two reasons, I suppose. One, if it's detected in the course of screening, we know that the outcome is always better than if it's presents on the basis of symptoms. And that's true even in the general population. So it is screen detected, and the biology of HNPCC tumors is more favorable. And there's a whole body of literature on why the tumor biology of HNPCC tumors is more favorable. So the bad news is, despite very aggressive surveillance, some patients are going to turn up with cancer despite that. But the good news is that the outcomes tend to be very, very good. Definitely better than 90% long-term survival.
Now, to make things clear, though, even though the disease is called HNPCC, these cancers still come from polyps, though.
Correct. So there's a school of thought that I tend to not agree with, but there's a school of thought that says that these cancers may occur de novo. So there are so-called aberrant crypts that are dysplastic. But a group in Germany who's doing some phenomenal work developing vaccines has identified what we call atypical crypts that are histologically normal, no dysplasia, but if you do immunostains, will actually show abnormal immunohistochemistry, loss of staining for the one of the mismatch repair proteins. And so we call those frame shift peptides. I don't want to get out in the details of that, but the thinking is that if you have histologically normal crypts that show evidence of microsatellite instability, it may be that those histologically normal but molecularly abnormal crypts may bypass the adenoma pathway altogether and go directly to cancer. I'm very skeptical. I think that these cancers do all start off as adenomas, but they're often very subtle. And I will say, I've definitely had the experience of very, very small, flat, innocent-looking adenomas having severe dysplasia in them. And so one of the things that I would really stress is very careful mapping of any polyp that is removed, and take great care to completely remove every polyp, because the degree of dysplasia may be very, very striking, despite an otherwise fairly innocent appearance.
Right, absolutely. That's how I first got into this, when you started sending these patients over for en bloc submucosal dissection of these things.
Right. So, I think one of the, and again, it's not that I'm not trying to convince everybody watching this podcast that they need to send their patients to Phil G. But I will say that if one encounters a challenging lesion, and I'm talking about some of these larger, irregular, flat, sort of geographic polyps in the right colon, a half-hearted attempt to completely remove it is probably not a good idea. That for these sorts of lesions, it's going to be a real undertaking to remove it. People have a busy schedule. It's not like, I'm not saying look for an excuse to beg off and bring them back for somebody else.
Right.
But to really properly remove some of these large irregular polyps, it'll take 45 minutes or an hour, even if you don't do ESD. So certainly one option would be biopsy the lesion, make sure there's not cancer, tattoo it, see what especially if they have HNPCC, like, this is a lesion I'm looking for, make sure there's not already cancer, map it carefully, and tattoo it so that it can be found again. And if we don't already know they have HNPCC, well, we can look at that tumor and see if it shows evidence of microsatellite instability and so forth, and do the genetic testing so that by the time they see a surgeon, if there's cancer and they need an operation, or the biopsies all come back benign, maybe they do need ESD, maybe we do need to send them to Phil G or his counterpart at the other institution, we actually know what we're up against before we undertake to remove that lesion. We know that it's HNPCC. We know that this lesion is going to be challenging. We should probably have a serious discussion with the patient about, do they want to have a simple laparoscopic right hemicolectomy, or more extensive extended right hemicolectomy, or should we attempt an ESD?
Absolutely.
Or EMR.
Absolutely.
So I think those are the real management, the real management dilemmas that you and I, last few years we deal with these on a day-to-day basis. And again, one of the things that I've always gone round and round with our surgeons over is where to put the dotted line if they do go to surgery, because we do know that these patients, even if they're cured of this first tumor, they're at risk of another tumor. And some of these patients, I've had it happen on my watch, have had 2 or 3 different operations for subsequent cancers. And so the more colon that's removed, the easier the surveillance is, and the less colon is still at risk. But that's probably a subject for a discussion with a panel of surgeons, some of whom will be more aggressive and some less in terms of the extent of resection.
Right, exactly. And that certainly brings into question various quality of life considerations and whatnot as well. It's just very interesting, talking to you about this and having had this experience, because, it's kind of funny you bring up biopsy and tattoo. The pendulum has swung so against biopsy and tattooing in the endoscopic resection world because it causes headaches and fibrosis and whatnot. But you and I have both had these experiences where some of these lesions in HMPCC are so subtle that you may actually have trouble finding it on the subsequent endoscopy.
Right, exactly. And so that's where, again, not to get out into the weeds of enhanced colonoscopy, but I did a lot of work with indigo carmine and different vital stains to identify these sometimes really flat but not necessarily small. I mean, some of these lesions that at first glance, there's something there. Is there not something there? I'm not sure. Let's spray it. And then you see some 4, 5, 6 centimeter lesion that just meanders all over the right colon that is almost perfectly flat and is terrifying because it could have been so easily missed. So they can be tiny, 3, 4, 5 millimeter lesions with severe dysplasia, or they can be these huge geographic but also subtle things. Very
even in your last years in practice, you started using AI.
Right. And so exactly. And so I think not to shill for AI, but I think it takes a certain amount of humility. I had been in practice for 33 years and had done 40,000 colonoscopies. But I had to, be humble and say, hey, this is just a tool to enhance the potential for identifying lesions that I otherwise might miss. And I've had a few where, it would light up on the AI, and I think I would have noticed that, but it caught it before I noticed it. I don't know whether I would have noticed it or not. Maybe if I blinked and moved on, I might have missed that. So thank you, AI. And we can, it lights up all kinds of stuff that's nothing, but we can ignore that. I mean, that's the beauty of the human mind is, we'll let the AI identify a lesion and say, oh, that's great. Thanks for helping me out and finding that, and I'll take care of it. But this other stuff I'll just ignore because it's artifact, and it's pretty easy to tell artifact from the real thing.
Right, and I think as all your colleagues, that's one of the things that we all have admired about you over the time that you've been our colleague, and that's the humility and the ability to incorporate new technologies, not be afraid of trying something new if you believe that it'll actually help you in your toolkit. I want to spend a couple of minutes on this. I know this interview, it's a very extended interview, but I do want to spend a couple of minutes on this, going through a very different aspect of you, and that is your role in original investigations, in major clinical trials, in being published in major journals on your chemoprevention studies. How did you get involved in this? And what have you kind of learned from your experiences in doing these all the major work?
Well, so most of our chemoprevention trials have been in FAP. the only major study in HNPCC chemoprevention, actually, I have to credit John Byrne with from the University of Newcastle in the UK, where aspirin was used in mismatch repair carriers, and showed no real benefit in eliminating or preventing adenomas, but a sustained benefit in reducing risk of cancer. And so a follow-up study looking at the right doses is being done. And one of the problems with that particular trial is that they're very expensive to do. And so without major pharmaceutical or NIH support, it's just very difficult to do that kind of study on a shoestring. And so we were very fortunate in the early 1990s that the NIH was interested in doing chemoprevention trials in FAP. In fact, I think they had been approached by pharmaceutical would-be partners saying, "Hey, we want to do a study of our drug. Will you help us support this," and so forth. And so the reason we got our first study going, Gideon Steinbach, now at the University of Washington, and I, there was an RFA from the NIH saying, "Hey, who wants to do a chemoprevention study in FAP using celecoxib?" And basically, the parameters of the request for applications made it very clear that the main eligibility for participation was you had to have a bunch of FAP patients. It makes sense. It's a rare disease, and you may know everything there is to know about chemoprevention, but if you don't have the patients, you can't enroll people. And so being a big cancer center, obviously people enroll in clinical chemotherapy trials all the time, but chemoprevention was kind of novel, certainly to us. But we did have a lot of FAP patients, and we wrote a proposal, and it got funded. And then we realized that we didn't really know that much about clinical trials and how much of the clinical oncology paradigm needed to be followed in a chemoprevention trial using, obviously much safer drugs with much healthier patients. So a lot of the considerations were somewhat different, but so much of the regulatory environment was new to us at the time, and has gotten, like everything else, more and more complicated as time has gone on. And so to do a clinical trial nowadays requires far more sophistication and familiarity with the issues of IRBs and all the regulatory trappings. And so I guess we were lucky that we had somebody like Ernie Hawk, who's now our Vice President of Prevention, who then was the medical contract officer at the NIH, kind of hold our hand, and some very thoughtful people with the pharmaceutical sponsor, the manufacturers, who helped us with putting the trial together. We had a lot of good help. And another shout out to Bernard Levine. He had gotten acquainted with the folks at St. Mark's Hospital in London, which was really the original polyposis center in the world, and got us hooked up with Robin Phillips, who's become a dear friend of mine, surgeon at St. Mark's. And so this was an international collaboration between MD Anderson and St. Mark's in London, our first trial. And so that was pretty exciting, pretty heady kind of stuff. So we've learned a lot about clinical trials, a lot about the importance of choosing the right endpoint to measure, and the challenges of doing that.
Absolutely. So as we start thinking about wrapping up, I want to ask you, when you look back at 30 plus years as an investigator, what do you consider to be some of your most proud accomplishments and contributions to the field?
Well, I think, personally, our perseverance in getting through the chemoprevention trials, and maybe more so than whether a given drug is effective or not, at least in the case of familial polyposis, recognizing that measuring endpoints is a very challenging undertaking. The FDA requires a measure of clinical benefit, and simply reducing the polyp burden from 100 polyps to 60 polyps. Sure, you've reduced the polyp burden, but they're still going to need an operation. And so it's been very, very difficult to formulate endpoints that will pass FDA muster. And so, in HNPCC, again, the only agent that's been shown effective was aspirin, and I think there's still no formal indication for aspirin from the FDA. Many of the guidelines, the NCCN guidelines and various societies' clinical practice guidelines do suggest consideration of aspirin in HNPCC. And so, coming back to personal, I think our work in chemoprevention, and what I guess, again, now that I'm retired, I would say that the hundreds and hundreds of patients and families, I guess I'm very flattered to be able to say that by the time I retired, I was well into the third generation. I don't know if I ever hit 4 generations, but well into the third generation of a given family. So taking care of grandma and mom and now, the son or daughter, it's very gratifying that they had enough confidence in what we had to offer that they would not only come back to us, but they would bring their extended family for surveillance and treatment as well.
Absolutely, and that's I believe the honor of trust is the highest honor. What advice do you have for young investigators, such as those who will likely be viewing this interview, in terms of success in clinical investigation?
Well, first of all, I would say to young people, especially people that may still be in training, is consider a career in high-risk familial genetic predisposition to GI cancer, because it's actually not that difficult. You don't really have to understand molecular genetics very well. Just like, we can be perfectly happy at a cancer center without knowing hardly anything about chemotherapy. Likewise, you can have a promising career in high-risk familial patient management and clinical trials without really knowing the nuances of molecular genetics. I certainly never presumed to. And so there are many career opportunities as HNPCC and related conditions are now well known and accepted. Most groups, even academic groups, don't really have anybody that's comfortable dealing with this. And so I suspect that there are many institutions, including academic ones, that would love to recruit someone who is well trained in this area. And there are ways of getting that sort of exposure, sometimes on the job exposure. So I would say to young people, let's face it, everybody wants to do therapeutic endoscopy, right? But not everybody can be. There's only so many lesions that require ESD. And so there are many people that are going to be disappointed that they don't get into an advanced endoscopy slot. Consider a career in high-risk familial patient management and the clinical trial opportunities that go with that.
You can do both.
You can do both. You can do both. You've actually been. We've had a lot of fun together with some of these patients, and so there certainly are people that are therapeutic endoscopists that have kind of earned their chops with these high-risk patients.
Absolutely. In closing, it's absolutely been a pleasure to interview you and hear your take on all this. This really is a very unique story to tell. The story from Patrick Lynch. Um, what would Henry Lynch think about this interview and about your accomplishments and where the field has gone in the last 34 years?
Well, I would like to think that he would be proud, but honestly, I don't really care. um, the thing is, I've developed some good self-esteem from this work, and self-esteem has to come from within. It really cannot come from without.
Right, right. Very good. Well, thank you again, Dr. Lynch. It's absolutely been a pleasure to interview you for this exciting project. This interview will be published with the June 2023 issue of IGIE. Please keep an eye out. Thank you again, Dr. Lynch.
Sure. You're very welcome. Thanks, Phil.
I heard you've been running a farm. Tell me about your farm.
My farm? Well, it's on a hill. It's on a hillside, and just keeping it mowed is a huge challenge because it's hard to mow things that are sideways. And on a tractor, if you tip a tractor over, they say wear a seatbelt, and there's like a roll bar on the tractor.
Oh.
Because they say if you're on a hillside sideways and it rolls over, crush injury is what people die of, and so it's a roll bar. So keep your seatbelt on, and if it rolls, just go ahead and roll with it. Don't jump off.
Wow. So, I'm assuming I guess roll with it, right? Is the saying.
Right.
What kind of attachments do you have for your tractor, and what's your favorite one, and what do you want for what's on your wish list?
Well, the main one. So the main one is mowing. What I want to get is a chipper. How you're driving down the street and they have these big orange asplin things where they put the tree branches in and grind them up. I need a chipper because we've got so much brush and little saplings and whatnot that I want to grind them up, because if you burn them, some of these weeds evidently have a lot of oil, and their seeds will explode, and then you've spread weed seeds all over the place. So they say burning is not a great idea. And so, mulching all this stuff is a real chore. So, the next attachment I'd like to get, probably rent it at least at first, is a chipper. They say that the PTO, the power takeoff, the thing that spins the attachments, they say the best kind of chipper is the one that's driven by one of those PTOs. And so you just feed all the stuff in and you get mulch.
So what do you do with your farm? Are you growing food? Are you raising animals, or is it just for fun?
My wife is big on flowers, so I've got to plant her flower garden. She's back in St. Louis with the newborn baby helping out. My daughter-in-law's got a great big giant garden, not really a farm, more of a giant garden with potatoes and all this kind of stuff. And then we have an orchard up on the hillside that we got our first tiny batch of apples last year, and so we're looking for apples and pears and grapes and all that good stuff. So it's starting to come together.
That's very good, very good. Well, happy planting and happy retirement.
Yeah, thanks.